So first things first, yeah, the amazingness that I got to experience on September 8th was my first baby Ethan. Yeah, he's absolutely adorable. But so that's what I've been working with since the 8th. It's been quite a roller coaster ride, but hope you bear with me today. So today we're going to be talking about strategic analysis. So what we're going to have here is my introduction, maybe 10 minutes, 15 minutes. So we're going to have a didactic session that Dr. Kumar will give you about more kind of the nuts and bolts. And then we're going to break into groups. If you paid attention to the numbers that you had when you signed in, that's going to be your group number. And it's going to take probably about an hour to do this. Please read over that session, because if you've read it over and you know what you're doing beforehand, you're going to get through it a lot quicker. Otherwise, we may run long, may have to cut you short. I don't want to do that. And then afterwards, we have the capstone groups like we were talking about. So what the heck is strategic analysis? So my Wikipedia did it real fast. So it's the process of developing a strategy for an organization by researching both the organization and also the environment in which it operates. Okay? So there are many ways to do this. Dr. Kumar is going to touch on it a bit more, but this is the underlying theme of this day, is how do you research and develop a strategy for your organization by looking both at the organization as well as the environment that you operate in. Okay? First things first, I want to test some of your knowledge of the environment that you operate in. Okay? So this is a quiz through the team at Gapminder created. It's a 13-question quiz. I want to put you guys through this. Okay? It's relatively simple questions about the world. Let's see how you fare. Okay? Let's see. Is Gapminder good? Is it gonna pull everywhere? Is it gonna pull up? Maybe, maybe not. Oh no. Hold on. Let's see if we can get this to work. Hold on. We had this working earlier. I don't think this one's going to work for us. We had it working earlier. Yeah. But, sorry. Technical. We were trying to be awesome, and then technical problems. We had this. No. I mean, it is this one. This is the strategic analysis. Why didn't it? Let's try it one more time. Opening it up. Hang with us.
Just gives you a little bit more time to download the app.
There we
Just
go.
working with you.
All right. Let's try this one more time. From the beginning. Oh, no. Let's do it. One more time. Like that.
I'll go to the next one if it's there.
Yeah, that's the answer is there. Okay, looks like pull everywhere is going to give us trouble here. Okay, so I guess I'll just add, yeah. Yeah, so it's not going to be as good. Okay, so I guess the next slide's going to give you the answer, and I don't want to do that. Dang it. Okay, close your eyes, I guess. Okay, so in all low-income countries across the world today, how many girls finish primary school? If you were at, yeah, thank you, C. You all nailed it. All right, so C, 60%, okay? So 60% of all low-income countries, girls finish primary school. Where does the majority of the world population live? The majority of the world population actually lives in middle-income countries, okay? In the last 20 years, the proportion of the world population living in extreme poverty has nearly halved, okay? What is the life expectancy of the world today? 70 years. That's the average in the world. There are 2 billion children in the world today, aged 0 to 15. And how many children will there be in the year 2100, according to the United Nations? It's not 4 billion, not 3 billion, but 2 billion children. So they expect it to remain about the same. The UN predicts that by 2100, the world population will have increased by another 4 billion people. And what would be the main reason? Not because we're having more children, not because we're living longer and having very old people, but because there will be many more adults, a much larger working population, actually. How did the number of deaths per year from natural disasters change over the last 100 years? The number of deaths from natural disasters in the last 100 years have decreased to less than half of what it was 100 years ago. And there are roughly 7 billion people in the world today, and which map shows where they live, which is representative? A. The vast majority of people live in Southeast Asia. Okay. And how many of the world's 1-year-old children today have been vaccinated against some form of disease? And that's 80%. 80% of people have been vaccinated against some form of disease. And worldwide, 30-year-old men have spent 10 years in school on average. And how many years have women of the same age spent in school? It's 9. So it's not where it should be, but it's better than at least what I thought. Okay. And in 1996, tigers, giant pandas, and black rhinos were all listed as endangered. How many of these 3 species were critically endangered today? None of them. And how many people in the world have access to some form of electricity? 80%. 80% of the world has access to some access to electricity. And then the gimme that I think all of you would get is global climate experts believe that over the next 100 years, the average temperature will get warmer. And that's the one that everybody seems to get. And so what I was hoping that you would get out of this, and I apologize that we had trouble with technical difficulties, what I was hoping that you would get out of this is, number one, that your perspective of what the world actually, what you think it is and what it probably actually is probably a little different if you went back and looked at the data. And in the world that we live in right now, a lot of people have opinions, but at the end of the day, what really matters are facts. Okay, and that's what I hope that we can get out of today, is that you can, leave here knowing that you should know not just what you feel is going on in your community, but what is actually happening. And Dr. Kumar is going to help us a little bit with some of the strategies that we use to be able to do that. Okay, cool. Let me pull you up. You got it.
So for those of you who don't know me, I think I know most of you. I think the new cohort haven't met most of the new cohort. I'm Dr. Kumar. I work with Chris in the Department of Emergency Medicine, and my focus is mainly international, global health and international public health. Let's see if I can. So really unfortunate that Jeff y'all couldn't do the poll everywhere, because that was awesome, because I tried it with Jeff earlier. I did the study, and I think I've done enough of academics to get pretty good at that study, at that survey, and I did pretty miserably at it. So I think I underestimated everything in that. So that's something that we should remember, that facts always overrule ideas and just all that we have. So today I'm going to talk a little bit about strategic analysis and of my presentation. I'm going to talk a little bit fast because we don't have too much time. It's going to be going to cover a few definitions, going to understand the 6 steps of situational assessment. We're going to talk about what data to use and where to find it, and also like some of what not to use. Also talk about SWOT analysis and force field analysis, and a little bit of Hale and Daly, the cohort. The first cohort, actually, if they remember my first presentation, I went through Hale and Daly in pretty good detail. Today I'll just go a little bit superficially, but I think when we come back to the global burden of disease, we'll go through Hale and Daly well later on. So definitions, I like Jeff's definition better than this one, but this is the WHO one, so they obviously made it more complicated. Strategic analysis, the ability to use systems thinking to analyze a diverse range of complex and interrelated factors, shaping health trends to formulate programs at local, national, and international levels. So basically, it's this. It's a snapshot of the present used to plan for the future. It's basically systemic analysis, very similar to what strategic analysis is. SWOT analysis is a type of examination of an organization. It was initially developed for Fortune 500 companies, and now it's moved on to public health and health-related aspects, where the internal strengths and weaknesses of organizations are evaluated, its opportunity for growth and improvement, and the threats the external environment presents to its survival. We have Hale and Daly. Hale is the number of years a person of a given age can expect to live in good health, taking account mortality and disability. And then you have Daly, which is the sum of years lost to premature deaths and years lived with disability. So this is the money slide. This is all that we're going to talk about today. So we're going to talk in detail about each one of them. But if you know this slide at the end, and at the end of the day, I think you've done enough. Like you've learned what I wanted to teach you also. Strategic analysis is basically analysis of a situation, creating a communication strategy coming up with a management plan and evaluation. That's a loop. And that's like anything with education, anything with industry, anything with business is all loop. Like you come up with a strategy, you come up with the management plan, you evaluate it, and then go up to the next step. So, and then you go in a loop pattern. So that's strategic analysis in a nutshell. So this is a situational assessment. So it's a 6-step process. And I'm going to go through each step individually. I have different names when I go through the steps, but basically it is, you start off with managing the planning process, then you conduct situational assessment, then you set goals, population of interest, outcomes, objectives, choose strategies and activities and assign resources, develop indicators, review the plan. It's basically feedback, implementation, evaluation, and then loop back to feedback, implementation, evaluation. That's all it is. It's not rocket science. It's pretty easy. And I think it's something that we do without acknowledging that we're doing it in a formal manner. So the first thing that you want to do is identify key questions to be answered. And whenever you go to any study, any public health project, any project that you're doing with research or public health, the first thing is what do you want to answer? What's the key question that you want to answer? So I like to. So most of the stuff is WHO, and a little bit of it is from the Canadian resources that I've used, very socialized. But the first thing is, what is the situation? There are 3 questions I like to answer. What is the situation? What is making the situation better or worse? And what possible actions can you take to deal with the situation? Those are the questions that usually like you should think about whenever thinking about a project. So to give an example, so we want to go to Hamtramck. Who's there? Nobody from that project. So we want to go to Hamtramck, and then we want to do a hypertension project. So why do we want to do a hypertension project in Hamtramck? So the first thing is, like, what is the situation of hypertension in Hamtramck? And second is, what is making the situation better or worse? Like, do they have enough education? Is it health education? Is it supplies or medication? Is it actually monitoring the blood pressure at home? What is making it better or worse? And what possible actions can you take to deal with the situation? So those should be your key questions that's, when you start off with any project. Then you should develop a data gathering plan. It's the second step is always data gathering. So how do you go about data and what type of data? So always try to get your net as wide as possible. Get a diverse type of data, like so community health status indicators, evaluation findings. So as large as you can get. The large method collection methods like literature review, focus groups, surveys, you can use all that to get your data. And source of data could be from peer-reviewed journals, community spokesmen, resource centers. So as you can see, you're getting data from all over, and so then it becomes really huge. And like, what do you do with all this huge data, and which data to use? So this is a little diagram that I've used in the past for the type of data sources that we use and breaking it into sections. So you have a surveillance system, you have a population-based sources, and you have institution-based sources. So when you're doing public health, and especially when you go to international sites, then these are the 3 main sources where you can get your data from. So the population-based system is 3. You get census, you have the vital registration system, and your household surveys. A lot of us actually do household surveys. So we basically go there, we conduct a household survey, get some data from that, and then use it. So there are multiple people who do household surveys, then put it into publication as a manuscript, so it's available, open access for people to see. Institutional-based resources are also what a lot of us use. We use records, use resource records, use service records, and use individual records of patients. So those are the different types of sources. And surveillance system I've kept separately, because surveillance system is what we try to use a lot outside the population-based resources and the institution-based resources. So a little bit about population-based sources. I'm going to go through this. I'm not going to read out everything out there. It's all in the slides, and you're going to get all the slides, so y'all can review it later on. So most national bodies have census, and they implement it every 10 years. US has one, India has one. So they usually cover the entire population, and they provide a good denominator when you're doing population subgroups. So it's a good source of information but only contain limited information on health. So it's more like demographic. Census, you talk more demographic. It doesn't contain that much information on truly health. Your vital registration system is national birth death certificates. So those are also used by us. They link to information on sex, geographical region, occupation, education. So that's a little bit more detailed about health than your census. And in many low and middle income countries, we see that vital registration system not collected properly. They do their best with the resources that they have, but when you actually do the analysis of them, you see that that's not up to the mark of what we want to do for doing using it for doing other studies. So what's the state of the vital registration system? So in 2009, the only 25% of the world population lived in countries where at least 90% of birth and deaths are registered. Only 34 countries, representing 15% of the global population, had high quality cause of death data, and 74 countries lacked data altogether about births and deaths. So you can see like it's not up to the mark of what we want it to be. So then household surveys. That's the most common one. Like I think I've done 3 studies in India and I've used household surveys for all of them. So we're now moving on to using population-based. It's much more difficult doing population-based. It's much more easier doing household. So most common, overall, most reliable data source for health inequality monitoring in low middle income. Represents for a specific population. There's it can be repeated over time. It can be repeated in different countries, and then you can analyze the different studies in different countries. But you can make sampling errors and non-sampling errors on this population. So then you have institutional based data sources, as I said before, easily and readily available. At a low cost, you can get the data, but it can be fragmented and of poor quality. So you have to be careful when you're getting data from low middle income countries, and especially when you're getting institutional data. Sometimes a lot of this data is not EMR based, and a lot of them is paper based. So getting that data is also pretty difficult collecting from the hospitals. And obviously, it's not representative of the whole population. A difference wherever the hospital is or wherever the institution is, that's where the data is going to represent, and doesn't truly represent maybe even the state in which that hospital is, just a little zone where the hospital is. Last, we want to come to the surveillance system. It can provide detailed data on a single condition or from selected sites. Useful for correction of over and under reporting, not always representative of a population. But again, it's a surveillance of a small area, so it doesn't represent the whole population. And some systems may collect little information relevant to the equity stratified. So it's basically some of the surveillances may truly not be appropriate to what you're actually trying to study out there. So these are the examples of surveillances, and the reason I put this slide is it's a little busy slide, but I think it sort of gives you an idea what surveillance is about. So you have outbreak disease surveillance, right? Name shows it aims to track cases of epidemic-prone diseases, and usually relies on data available in hospitals or in labs. So, and then you have sentinel surveillance. Sentinel is basically sample of clinic. You take a sample of clinics and you do an analysis of them, and then you could do a cluster. You could do a random sampling of the hospitals, and you can do. So example was HIV and malaria studies, which were done in the low middle income countries, especially Africa. The risk factor surveillance basically describes data collection analysis in non-communicable diseases monitoring. So that's basically you're studying the risk factors for getting non-communicable diseases. So that's the type of, and then you have demographic surveillance. So, and that's usually you can get the demographic survey similar to census, but it's conducted more in a localized and in a focused manner in a smaller place. So like having longitudinal birth and death registration system from a local population, a cause of death and health related data to get from a local population. So gathering the data. So now we have talked about all the different types of data that are available out there. And the next step we want to do is how are we going to gather their data? So it's very important that you need to gather the data. The right people should be there to collect the right data. You can't. There was one of the studies that I did. I don't want to mention it. There might be somebody who did or was a part of that study. So we had school students who were actually collecting the data. It was passed through the IRB, and then later on I was actually reviewing the data, and I realized like the data truly is not clear of biases. The example I'm giving you is like they were doing a questionnaire, and these are small kids who were running the questionnaire, and they were asking older patients about clinical disorder. And when the patients don't like to talk about the clinical disorder, so the kids thought that it would be nice to like give them a little push in the direction of what they wanted the answer to be, which is definitely confounding. And so it becomes an issue when all that data is collected and then you have a statistically significant result. Because now, am I going to believe that that result is truly statistically significant, or it's because each of these students have actually push the patients to give an answer, which is now making the data statistically significant. So I have to release that when I'm actually writing up the manuscript. It's truly unethical if I don't do that. So if I had gone the first step initially, I had made sure that the people who were collecting the data were not students or somebody who were trained and who were aware that they should not be guiding the patients into giving the answers as they think would be right, then I think the answer might have, the results could have been different. Second thing is keep good records. The data and the source, you should have records of that. It's very important. Uh, uh, Say like any data that you collect for a research study should be IRB can come and ask for it for 5 years. So you can't get rid of your data for 5 years. So it's always useful to keep it in EMR rather than paper form. So a broad search and critically appraise your sources before organizing, synthesizing, and summarizing. That's very important. So once you get all the data, the next things you have to do is organize, synthesize, and summarize your data. So before you organize, synthesize, and summarize your data, critically appraise your data. What is critically appraise your data? It's basically get somebody else to review the data. That's what I look like to do. Like so, the way it was conducted, if I find a fault at that time, I might actually, it might be easier to actually so suppose you're doing a data gathering from an EMR and I have somebody else review the data and he says these are the faults that I found, it'll be easier for me to go back and get the data at that time rather than summarize it and then try to go back and get the data. So it's very important that you do it at that point. And for primary data collection, make sure it's ethical using informed consent. And that's a big thing with research. Any research that you do, if it's primary data, that means you have got data from a patient directly, make sure that you have informed consent from the patient. So the next step is organize, synthesize, and summarize the data. So it's a lot of things that you got to do. So what did you discover? What is the situation? You summarize the trends, public perception, stakeholder concerns. What is the one factor that is influencing the situation? Is it making the situation better? Is it making the situation worse? What possible action might be taken? So all that is comes to play when you're organizing, synthesizing, summarizing the data. So to make it easy, there are two ways of analyzing it. One's called a SWOT analysis and it's called a field force analysis. So I'm going to talk a little bit about SWOT analysis. So what's SWOT analysis? SWOT is strength, weakness, opportunities, and threat. So it's examination of an organization's, this is the definition again by WHO, internal strengths and weaknesses, its opportunity for growth and improvement, and the threats the external environment presents to its survival. So again, it was initially started off for industry. So you see that you can apply this to any industry. So it's what is the strength of your organization? What's the credibility of your organization's funders? What are the weaknesses? What is the internal accountability mechanism? And what are the different opportunities out there to make it better? And what is the threat that's there to make this organization not function properly? So it's easy to say SWOT, but then how are we going to get the data for SWOT? So we have a 2x2 diagram which was created, and that's what SWOT analysis is. So this 2x2 diagram helps you assimilate the different information that's coming out there and then put it in a format in which you could review it. So as you can see in the column, you have the helpful, which is to achieve the objectives, which are the strengths and the opportunities, and then you have the harmful, harmful in achieving the objective, which is the weakness and the threats. And then you have internal origin and then external origin. So what you do is basically to every part of the organization, you give them the different questions. You give them what's been helpful, what's internal been helpful, what's external been helpful, what's harmful, what's been internal been harmful, what's external been harmful, what are weaknesses, what are threats. Put it together in a 4x4 and then talk about each one of them. And then that's when you get a good SWOT analysis. And then you put the points out like how we did out here. So write it in a SWOT manner out here, and then you're able to assimilate the data, the information, which basically helps you analyze the data that's come out there. So that's what you do in a SWOT analysis. So the other one is a force field analysis, a little bit more easier than a SWOT analysis. Force field analysis is basically you have a societal organization environment, you have network, spelling is wrong, and you have individuals. And so then you see that at what level of the environment does this factor influence the situation, and is it making the situation better or worse? So is at what factor the factor is making it better, the factor is making it worse. So here is a community support is making it better, and then you said like what are the factors making it worse? So poverty, single parent, child gender. So these are the common ones. I just give an example of a study which is being conducted in a village with child health. It's similar to what Jeff is going to do later on today. So So this is a force field analysis of the situation that's there. Next step is communicating the information, and that's key. So now you have sort of got your data, you sort of analyze your data, you sort of come to an understanding of what your data truly represents. Next, what do you do? Next, you communicate the information. It's a very key part of getting data. So just by getting the data is not good enough. Then you have to publicize your data. There are different ways of publicizing data. You must figure out who your key audiences are. You must find out who the policymakers are, who are the funders, who are affected, like who are the patients who are affected by this. You have to get that data back to them. What is the objective for each audience? Like, see, each audience you want to give like the data is full. You don't want to give everything to every audience. So you want to cater the data that you want to give to each audience separately. And then your methods of communication, whether written or verbal, or the products to be developed for communication, whether you want to send an email, whether you want to put it as a media, whether you want to give a news article out, whether you want to publicize, make a manuscript. It depends on how you want to put it, how you want to communicate the information. So next one is how to proceed with the planning. So that's the last step, is basically loop back. What are the gaps in data quality or quantity related to stakeholder expectations? What is your current perception about your ability to have an impact on situation, available time, financial resources, and mandate? And what are your next steps in the planning process? So that's the loop back. So these are the 6 steps for systems analysis. I went through it quickly because I don't want to spend too much time right now. I think these are all there in your text. It's Jeff has sent out good reading for you all to do. I think it's easy reading and it gives you a good idea of strategic analysis. There's a full textbook out there, I think, you send out about strategic analysis. You don't have to read the whole textbook, but this is the gist what is there in the textbook. So next, I want to talk a little bit about measuring health and diseases. So why would you want to measure, and how would you want to measure? So why is you want to assess health status over time. You want to reduce disease consequences. You want to the application of evidence-based public health practice. How is you want to do incidence and prevalence. You want to do severity. You could do premature mortality and extent of disability. Consequences like health, social, economic consequences, and you could do type of people affected, gender, age disparity. So these are different types of the health measurements that we can do. So global health indicators. So when we talk about a measurement of health, we're trying to get good global health indicators. We have to figure out, it's very difficult to find out what is the ideal global health indicator. But there are many global health indicators that have been studied over the years. A good global health indicator by definition should be uniformly applied internationally. So if you have the indicator in India, you should be able to use the same indicator in USA, in Scotland, in Norway. Anyway, you should have the same. You should be able to use the same indicator. It should be valid. They should be good validity. So by validity, you mean it should be valid, reliable, and readily reproducible, or interpretable. So it's interpretable and reproducible both. Feasibility, whether it's affordable, whether it's technologically feasible, and the utility, and what is the utility for this health indicator. It's useful to make decisions, and can it be acted upon at various levels. So those are the characteristics that I would want in an ideal indicator. So these are the examples of global health indicators that are available. So life expectancy at birth, mortality rate, case disability ratio, health expectancy. In health expectancy, you have disability-free life expectancy and health-adjusted life expectancy. And then for measuring health gap, which is the health life lost, you have healthy life years and you have disability-adjusted life years. So those are the common ones. There are other ones I haven't mentioned out here, but those are common and important ones that you use. Of these, the two that I'm going to talk a little bit about is Hale and Daly. So health-adjusted life years and disability-adjusted life years. So what is health-adjusted life years? So health-adjusted life years is number of years a person of a given age can expect to live in good health, taking account of mortality and disability. So in 1993, WHO, when they took out their, the book, they actually they calculated the Hale for almost all countries. So the Hale is a number that's given for health-adjusted life years or for different countries. And then you have disability-adjusted life year, which basically is calculated for each condition. So it's the sum of years lost to premature deaths and years lived with disability. So again, it came out in the 1993 World Development Report. That's the same time the Hale came out. So it does the health gap measures and years of healthy life lost. So I always like pictures, I think it's much more easier to remember when you have pictures. So daily is years life lost plus years equivalent of years of healthy life lost due to disability. So that's YLL plus YLD. And you can see out here, that's really small. So it's basically this daily is equal to YLD plus YLL. I'm going to give a little problem out here since I've been talking for most of 20 minutes. And I'm going to have you guys just answer this question for me. So years, I'm doing a problem for you. So years life lost is equal to N into LX, which is LX is equal to standard life expectancy age of birth, and N is equal to number of deaths in the population. X is the age of death. So can you tell me what the year YLL for 10 deaths at 50 years is? Yeah, what are you missing? LX, right? How do you calculate LX? So when you open your, there's a diagram, actually, WHO in 1993, in the report they came out with the dailies. So in the diagram, at the age of 50, you can find out what the standard life expectancy, and in this case it's 34. So 10 into 34 is 340 years life lost. So that's how you find the YLL. Okay, so when you open, anyone have, actually you can Google it. So you'll be able to find the Global Health Report daily calculation. So there's a graph, and for every year you can find out what is your standard life expectancy at the age of death. The second one is years lived with disability. Life tables, yes. Use life tables.
Yeah. So the where we get the life expectancy is basically we're taking life tables. If you look into that a little bit further, if you're interested in this, that's how we get what's the expected average life expectancy. Looking at that, it's a little more in depth than what we're doing, but yeah, that's where we get more.
So there is details about how they can change the variables out there, but just basically that's what it is. And in this case, YLD is equal to I, which is number of incident cases in the population, DW, which is the disability weight, which scales from 0 to 1, and D is duration of disease disability. And then you have deaths at 50 again. Oh, sorry. So again, there's an example out here, 10 cases of mental retardation due to Laere. And again, you have to use that table out there, and then you get 10 into 0.36 into 80, which is basically 288 YLD. So the final daily is basically YLL plus YLD, which is basically 344 plus 288 in this case. Why is what? Yeah. So why do I spend a little bit extra on daily? The reason I spend a little bit extra on daily is because that's a term that you're going to hear a lot when you do global health. Because it's one of the global indicators which truly has most of the features that I would like to have in an ideal global health indicator. But there are some criticisms for the daily too. So the criticisms I enumerated out here, you can go through it, because I'll run through them. It's an expert versus community or patient value of health. So it's an expert's valuation of health. So that graph was built by experts and not truly what's on the ground. It discriminates against young and old, so the extremes are discriminated upon. So that's the variable I was talking about. So you can do a variable charting to sort of reduce the discrimination. And disability additives in nature and could exceed 1. So when you go back to that slide, you can see the scale is 0 to 1 for disability weight. But when you add different disabilities, like suppose you're talking about 5 disabilities and you want to add the daily for 5 disabilities, then you might land up with greater than 1 because you're collecting fractions and adding them together. So it might be more than 1, so more than dead. So no priority given to worse off, no prioritization for people with limited treatment potential, does not access qualitative differences in outcomes, no male-female differences, and discounting future health outcomes. So these are all the drawbacks for daily, but I don't think that's too much of a drawback considering that you're trying to get a global health indicator which will be uniform all around the world. So disease severity score is used in calculation dailies according to their impact in our life are given a score of 0 to 1. Which of the following statements is correct interpretation of these values. So if you don't get this, I'm going to bang my head. Okay, I count 5 in my head. That's why I talk to my son, like 5 in my head. What's the answer? 1 means disease with high impact, 0 means absence of disease, 0 means death, 1 means absence of disease.
Raise your hand for 1. Raise your hand for 2.
Awesome. More. 2. Yeah, there you go. Okay.
And 4.
Okay, so that's the answer. Okay, so I think 25 minutes. I think we'll be starting off the exercise which Jeff is going to talk about. It's pretty exciting. I do want you all to spend to pay attention to what Jeff has to say in the beginning, because if you don't pay attention to that, you'll totally miss out on the whole exercise. Thank you.